Thank you, Professor Marcos. Thank you, Professor Sami. It's a privilege to be with you. Marcos asked me, give me some topic as a lecture. So I actually prepared as a lecture rather than kind of a personal series, more of what exists in the literature. But I definitely thought we are sitting in the galaxy of august audience who are doing a lot of work on CP younger tumor. Have we reached to a stage where we can with confidence say that all has been accomplished or we are still struggling? So when I see myself in that position, I still feel every day I'm struggling almost in each and every aspect of the acoustic schwannoma. And I'm trying to list that. Maybe your experiences are different from mine, but then I personally think all of us struggling even today, despite having produced best of the results, as we know. If we get to see a picture like this during our surgery, we are very happy. All nerves are very distinctly seen. Tumor is out. Yeah, there we go. There it is. Just a second. Yeah. Sorry for that. But then if we see picture like this during surgery, we are very happy. And believe me, it is not always the case. We may be happy to see pictures in regular time, but then I find that there are many issues which pertains to struggles, and that struggle includes putting the patient in observation whether should something be done in an incidentally detected tumor. In my setup, the delayed detection, patient coming up with extra large tumor, 4B, brainstem compression, midline shift is almost 80% of our series, then reported in most of the places. And I still been trying to figure out, are we more resistant to the symptom or are we ignoring those symptoms? Or is there a delay in picking up? Still, there is a struggle on it. We have MRI almost every center across the India, and still the tumor which are coming are of huge size. So I still debate, our symptoms are getting delayed, or is there some ignorance on part of our society? Now, in addition, I still feel there is not a uniformity in acceptance of what type of classifications in various grading should be adhered to. We do not have luxury of small lesions. Problem of hydrocephalus still comes with us. And literature is literally silent about brainstem microcontusions pre-existing or even happening after the tumor has been removed, and the changes which are actually affecting, despite doing a very good surgery, the patient's outcome may be poor. So I still feel that aspect is still troubling us. Yes, of course, all cranial preservation and patient coming up with residual tumor. In addition, the problem of tracheostomy, infection, chest, everything. Almost every day we see these cases without exceptions. We have no hesitation is saying that it's very, very common in March. Also have frustrations of unexpected outcome despite having done good surgery. Professor Sami is sitting, maybe his experience is very different, but I do come across approximately 5% of the cases despite having done all good, intraoperative, everything is good. But I still do not have a very good explanation to say why this patient has not made up as per we desired. I said there were approximately 8,695 publications as a couple of days back. And if you see, most of the publications are from US, Germany, UK. The top 10 most prolific authors had been Link, Carrison, Neff, Mayo Clinic, University of California, and Harvard had produced the maximum number of publications in acoustic schwannoma as per the latest publications. So, very interesting thing which I also noticed was the median age has increased gradually from 49 years in 1976 to 60 years in 2015. So I've still not been able to figure out why the median age of picking up the tumor has gone up rather than it should have gone down, because we have available screening imaging available. So while the median age literature is talking is increased from 49, is it because of longevity of survival, which has something to do with the occurrence of the acoustic schwannoma? Sorry, I don't have an answer to that. All of you know about this. Harvey Cushing described this bilateral, then Oliver Kona 20% mortality despite operative microscope, intraoperative monitoring, advances of neuroanesthesia. We are having the struggles which are continuing. Now, first struggle comes to my resident asking which classification should we be following when we are describing the acoustic schwannoma. There are various classifications available. Pool's House, Hanover classification. Of lately, ENT colleagues have started talking of much more on acoustic schwannoma than the neurosurgical colleagues, and they say it should be anatomical versus geometrical classification, which also be related with the morphometry of the posterior fossa, which is obviously has to have some relationship with the symptomatology of these patients. Clinical, we all know, we not go to that. And we all know about the various kinds of classification. Imaging, we all know. Imaging, we all know. Pathology, we all know, and not Anthony type A, B will explain. Now, I found very interesting observation. 2003, there is a consensus meeting of the ENT colleagues, which have come up with a very beautiful paper, which is talking of so many things which we keep on debating. And I was surprised. I'm not aware if there has been any consensus meeting across the neurosurgical forum, which have come up with guidelines to be followed by each one of us, that the ENT people have already published it, and I found it a very interesting paper was while reading it. It says that 29% increase in the first year with the highest mean increase of 62% in an asymptomatically detected acoustic schwannoma, meaning thereby all schwannomas are bound to increase gradually irrespective of. Another interesting thing which I found was European guideline, oncological guideline in the diagnosis and vestibular schwannoma. And in this paper, they have followed evidences and recommendations which we are scientifically available means familiar with. And this was disturbing. Struggle for the survival of neurosurgeon. If you see it, it says spontaneous versus small asymptomatic vestibular schwannoma observation or stereotactic radiosurgery. Spontaneous with complete hearing loss again says observation versus SR is superior to surgery. Spontaneous vestibular schwannoma large with brainstem compression, surgery is inferior to combination of surgery and SRS. NF2 surgery and SRS, or maybe it talks about the bevacizumab in the treatment of neurofibromatosis. Nowhere it is showing that the surgery has superiority in treating in all types of vestibular schwannoma. And that's very, very disturbing when we see guidelines which have been published. None of it. Over here it says observation SR is superior to surgery, and over here it says it is inferior to that. So it was disturbing. Are we going to struggle? Also, I find literature, various terminology which have been given: gross total removal, near total removal, subtotal removal, planned subtotal, stage resection, and rescue surgery. Rescue means after SRS, if the patient comes, you have to operate. Stage means you first stage you do retromastoid followed by translabyrinthine, because it says nerves become more robust. It is possible for remodulation of the nerves and they may be able to survive it. Now, I also studied the literature outcome of various types of procedures which are available today in terms of their success rate, seventh nerve preservation, cochlear preservation, progression-free survival, recurrence, and quality of life. And mind it, it is a pool data of all published literature recently. And what does it show? Gross total removal is possible only in 77%, not 100%. And if we see seventh nerve preservation in gross total is 60%. Mind it, it is pooled data, not in the best hand. Whereas planned STR with SRS has much better seventh nerve preservation than said by otherwise. Cochlear nerve preservation was least with the gross total removal. Progression-free survival was best. Recurrence obviously is least when we have a gross total removal, but the quality of life was poor. So, I mean, my evidence in the literature is talking something which makes me scary as well. We have various approaches: RMS, middle fossa approach, translabyrinthine, And even if I say in terms of these three approaches, quality of life as per literature still remains the same. One is not talking superiority of one approach over another. This is again pool data, not individual experiences. Please note those words as well. IONM facial monitoring, cochlear nerve monitoring, radiosurgery. Now, upfront radiosurgery is gaining popularity. Go ahead for radiosurgery directly and maybe subtotal resection with SRS. I find most of the people in the younger generation have started believing more on this. Remove less, there are more chances of preservation of neurovascular structure and subject the patient for SRS. It sounds good, but it is some type of warning for the skill development for the neurosurgery. That is what literature says. Follow-up, yes, usual role of bevacizumab, NF2. I was not aware about it. When I researched the literature, it is found to be very good in the treatment of neurofibromatosis 2 with acoustic schwannoma. Whether it will be used for de novo schwannoma, I absolutely have no knowledge. Now, my personal experience says that if my brainstem shows changes at the time of initial MRI images, which we often try to look for, we look for a arachnoidal cap, vascularity, but if your brainstem is showing the changes pre-existing, this patient is going to have bad prognosis, whatever you may do, and that has been our experience also. Look at this also. Tumor is over in this area, but the brainstem is already showing either edema or ischemic kind of changes, which I often found we do not work. Some of my cases, we do get large tumor midline shift. Even the small retromastoid connectomy are difficult, so I do not hesitate in making my connectomy larger up to midline, and I believe that will allow my retraction a bit more easier rather than I'm pushing up the things, and we are able to remove. And mind is in conferences, normally we would show the best of our results. So am I doing. I'm trying to show some of them, but then there are problems of residual tumors because of various reasons, which need not be discussed here. But then we do come across grade 1 to grade 4 facial nerve palsies, despite of having 20 to 25 year experience of neurosurgery. And also please remember in setups like they are, we have a various level of expertise who are operating. Somebody may have experience of 10 years, some may have 20 years. So at the pool data or in fact in an institution, we are bound to see mixed result like this, we say, oh, it's too small, we will be able to do it. But then we normally would be getting large tumors most of the time, and we are very happy whenever we see a tumor like this. Some compression onto the brainstem, not much of a change. It gives a sense of a confidence that most of us in our setups would be able to remove it safely, but it doesn't happen. We do lands up into the issues, and that is the message was that our struggle continues. So to conclude, I'll say vestibular schwannoma treatment outcome in strict term is a reflection of surgeon experience and bit of patient luck. In an emerging scenario of radiosurgery, the risk of operation versus performing surgery for gaining experience for better outcome will take away the merits in favor of radiosurgery. There is a definite role of surgery for recurrent, large residual post-SRS non-responder cases, because I still feel as a surgeon, these are the care which will be, categories which will be useful for us. But that until there is a universal reproducible result as that of Professor Sami by the junior or the middle level expertise, there shall remain a debate against the surgery in our literature. Thank you so much.